Hello students, I am Dr. Ramakrishna Chaitanya, your anesthesia faculty. So welcome to this NEET-PG 2025 anesthesia recall session. Right? One more exam is done, one more academic year is gone. Right? So we are back here with our old ritual, the recall session. Welcome to this recall session. The whole purpose of doing a recall session is to tell you that how the pattern of the questions are changing. Those who have attempted this examination, first of all, I would like to say congratulations to all of you, because I know it must be mentally tiring for you, right? It might be physically exhausted for you. So what we will do here is, without wasting much time, we will go back and see what are the questions that have been asked in your examinations. And as usual in anesthesia, we got around 4 questions directly from the anesthesia lectures and 2 questions are integrated. So what I wanted to do in this session is, I would like to do only the direct questions that have been asked from the anesthesia sessions. So without wasting much time, shall I see the questions what we have been asked in your examination? Right. So what's the first question? The first question is, a 50-year-old male with COVID developed ARDS and is on mechanical ventilation with PaO2 by FiO2 ratio of 100. PaO2 by FiO2 ratio of 100. What is the most appropriate ventilatory strategy for this patient? Right. Now this question is almost, this question we have discussed many times, because this is not the first time that this has been asked. Right. From the time of COVID, one or other question has been asked in your entrance examination. What is the difference between the previous questions and this question is, in this question, I have clearly mentioned that this is a case of ARDS. This is a case of ARDS, right? That means a restrictive pattern of lung disorder. Restrictive pattern of lung disorder. And one more point they have mentioned very clearly is the PaO2 by FiO2 ratio is 100. That means it is severe ARDS. It is severe ARDS. What happens in the severe ARDS? In ARDS, the lung compliance is decreased. The lung compliance is decreased. What happens is very simple. The lung, the compliance means, imagine a balloon, right? Take a balloon. If you take a balloon and if you are blowing a balloon, what will happen? The balloon will expand, right? What is this expansion called? This is called compliance. Don't think it is elasticity, right? So what do you mean by elasticity then? The elasticity means the moment you blow up a balloon and release it, it will come back to its original position. So elasticity is defined as the property of the substance to bring back to its original state. Whereas compliance means the change in volume to the change in the pressure. Right. So in severe ARDS, the compliance of the balloon or the compliance of the lung has been reduced. That means it is very, very, very difficult to expand the lungs for you. Okay. So whenever the lung is getting very, very difficult for expansion, the first thing what we will do is, we will not try to force open the lungs. The moment you try to force open the lungs, it will lead to rupture of your alveoli and it can lead to lot of complications, barotrauma. Okay, so our goal in any patient with ARDS is to put the patient with low tidal volume, and we call this concept as baby lung concept. Okay, why do we mean by low tidal volume? Means somewhere between 4 to 6 ml per kg. It depends on the institution to institution, but on an average note, we'll keep around 4 to 6 ml per kg. Because if I put more volume, obviously it is very, very difficult. Compliance is decreased. So it might lead to barotrauma. Okay. So the low tidal volume. So out of 4 options, what they have asked, where is the low tidal volume? Okay. Here is your low tidal volume. Here is your low tidal volume. So you can straightforward cut down the 2 things, A and C options. Right. What about the PEEP? What do you mean by PEEP? PEEP means positive and expiratory pressure. Okay, we all know this. Last year also, 2024, in your NEET-PG entrance examination, there was one question on the PEEP. This year also, there was a question, more or less direct or indirect question, right? So, what do you mean by PEEP? PEEP means whenever you blow the balloon, what will happen is this balloon will come back, but it will not become zero. Right? Why? Because in your lungs, there is something, leave about balloon, in your lungs, there is something inside the lungs that is called surfactant, which will prevent the collapse of the alveoli. But in ARDS, severe ARDS, because the compliance is decreased, the lung walls, they try to collapse with each other. And once the lung walls have been collapsed, what will happen? No force in this world can reopen up the lung. right? So the compliance is decreased. At the same time, there is a high chance the lung walls will collapse. In order to prevent this collapse of the lung, we do something called as recruitment maneuvers. Recruitment maneuvers. So what do you mean by recruitment? That means we prevent the lung being collapsed. Further thing, what we do is whenever we are inflating, we will put low tidal volume. Whenever the lung is deflating, at the end of expiration, we will apply some amount of positive pressure so that the collapse of the alveoli can be prevented. Okay, so we will apply PEEP. That is called as we apply some amount of positive and expiratory pressure. Very good. Right. Now, what is the point? Whether to put high PEEP or whether to put low PEEP? That is the biggest question. Now, low PEEP, as per definition, is generally we take around 5 to 6 centimeters of water. Okay, 5 to 6 centimeters of water, right? Physiologically, in our body also, there will be some amount of PEEP that will be around 3 or 2 to 3 centimeters of water, right? When we call it as low PEEP, it is called around 5 to 6 centimeters of water. And when we put low PEEP, obviously the whole advantage of putting a patient on mechanical ventilator is lost. So, we will not put the patient on the low PEEP mode. Can you understand it? So what is the only option that is left over? The only option that is left over is high PEEP. If you are not putting a patient on high PEEP, then definitely you are not doing the recruitment maneuvers. The lung condition is not going to improve at all. Not only application of the PEEP in ARDS patients, what we do is, in order to improve the compliance, we also do prone position ventilation. Prone position ventilation. You might have heard this word in your medicine class also. So whenever a patient is on mechanical ventilator, in order to improve the lung compliance, we'll put the patient in prone position. The moment the patient is in prone position, the weight of the thoracic structures like your heart and the mediastinal structures, that will be removed, and the compliance of the lung is also improved. Okay, so that's one more strategy what we use. And one more thing what we do is, we do inverse ratio ventilation. Inverse ratio ventilation. That means we will give good time for the lungs to expand. With that small tidal volume also, we will not force up the things. We will not hurry up the things. We will give some more time for the lungs to expand. That's called inverse ratio ventilation. So these are all the maneuvers what we do to protect the lung. From the disease process. Have you understood it? So what is the correct answer in this MCQ? The correct answer is high PEEP and low tidal volume. So this is the correct answer for your entrance examination. Hope you have marked right for it. So we have made this session in Marrow, where we have done lot of questions, or the ventilatory settings. Don't think like before last year, before 2024, I used to tell to the students, in the NEET-PG they are not asking any ventilatory based settings, right? So last year also we did one session on ventilatory management, where we discussed about lot of modes of the ventilation, etc., etc. But can you see the difference? 2024 they asked about a PEEP. 2025 they are asking about the ventilatory setting. Maybe in 2026 what can happen, you can only imagine, right? So if you haven't heard the lecture on the ventilatory management, etc., please have a look at it, because many undergraduate students, they don't get exposed to themselves during their undergraduation period in ICUs or handling the critically ill patients. Okay, so that's the first question for you. The answer is high PEEP and low tidal volume. Shall we see the second question? The second question that has been asked, okay, general anesthesia with sevoflurane and succinylcholine was administered to the patient undergoing abdominal surgery. Post-operatively, the patient developed persistent muscle contractions, hyperthermia and tachycardia. Which of the following is the lifesaver in this situation? A very classical question that has been asked. This is a very common pattern of questions what we are expecting in your examinations. Maybe in your upcoming NEET-PG also this kind of questions will be asked. Right? That's a clinical pattern of questions. So by looking at this case scenario, what is your diagnosis you can make? Okay, the diagnosis is pretty straightforward diagnosis. That's the case of malignant hyperthermia. Sir, malignant hyperthermia. Many students, they have this a wrong concept. Malignant hyperthermia means it should develop only intraoperatively. No, it can develop. It can develop in the post-operative period also. This is what written in the textbook. This has been emphasized in our video lectures repeatedly. Yes, classically, it will be presenting the moment I give anesthesia for a susceptible person. That is the classical presentation. But there are some unclassical presentations also. During the surgery or in the post-operative period also, they can develop this malignant hyperthermia. So, post-operatively, don't get confused by this word. Okay, even in the video lectures also of the marrow, I have said we made a separate module on malignant hyperthermia because this question has been asked last year in 2024 NEET-PG entrance examination also. Right? At the time, it was a different question. What was the etiology? They have given the same clinical scenario. They asked the etiology, something like that. So this year, they asked what is the drug of management. Right? So post-operatively, the first confusing word for the most of the students. So I am removing this confusion. That means it can be a malignant hyperthermia. Sir, how do you know it is a malignant hyperthermia? Malignant hyperthermia, the classical presentation of malignant hyperthermia is sudden unexplained tachycardia, increase in blood pressure, increase in body temperature, increase in EtCO2 levels. So this is the classical description. EtCO2 is the most sensitive sign to detect or to say this is malignant hyperthermia. Can you see in this question what they have asked? Post-operatively, patient developed a persistent muscle contraction. Can you see here? Because in malignant hyperthermia, the problem is mutations at ryanodine receptors. Mutations at ryanodine receptors, there will be increased calcium, and this calcium can lead to excess of muscle contractions. Excess of muscle contractions. So, muscle contractions is present. I said you increased body temperature. The name itself is telling you hyperthermia. Okay, and tachycardia. Right? So, this is a classical case of malignant hyperthermia. Don't get confused that this can be a seizure episode. This situation can be a seizure episode. It can be a seizure episode, but I will not say seizure episode because in seizure episode, the body temperature will not increase that much. The first point. Muscle contraction can be happening, but this is not a case where we can think of seizure episode. It is, it will be classically giving you a symptoms of RO, generalized tonic-clonic seizures, tongue biting, eyeball rolling, frothy secretions from the oral cavity, and all these things. If at all that is coming, then I might be thinking or pointing towards the seizure episode. So this is not a seizure episode. If it is not a seizure episode, diazepam is an outdated drug. Diazepam is one drug which I have been telling to the students many times. This is an outdated drug. When I did my post-graduation in 2007, this was an outdated drug. Okay, right? Yes, some examiners are still following this diazepam. It's okay, fine. But here in this situation, diazepam is not a right drug. So paracetamol, there is no role of paracetamol at all. Because paracetamol, Dolo, 650 tablets, all these tablets, they are used for simple fevers. It's not a simple thing which you can understand, right? Propranolol can be considered, but propranolol is only, generally we take propranolol only in case of thyroid storm. That too, once the patient is stabilized. Because propranolol has got an activity of anti-thyroid activity, which you all know, right? So why can't it be a thyroid storm's case? Thyroid storm also will have increased heart rate, increased blood pressure, increased body temperature. That's also a hypermetabolic state. But classically, thyroid storm will be presented in a thyroid surgery case. And thyroid storm definitely means during the surgery. The main reason for thyroid storm is the surgeon, whenever he is manipulating the thyroid gland, it can lead to thyroid storm. Post-operatively, there is a less chance. If it is a thyroid surgery, nowhere it has been mentioned. Right? Nowhere it has been mentioned that it is a thyroid surgery. And second thing is, in post-operative thyroid surgery, we will anticipate hypocalcemia because parathyroid glands and all that stuff will come. So here in this question, classically they said that there is a general anesthetic given. Patient developed hyperthermia, tachycardia, muscle contractions. In thyroid storm, muscle contractions will not be there. Muscle contractions will not be there. Okay, so it cannot be propranolol also. Okay, right, then what is the leftover drug? The drug of choice in management of patient with malignant hyperthermia is dantrolene sodium. Is it clear? The answer is very clear for you. Dantrolene sodium. Okay, right. Shall we see the third question that has been asked? So, what are the differential diagnoses of malignant hyperthermia? Just now we have made 2 or 3 differential diagnoses. The first one is seizure episode. The second one is a thyroid storm. The third one, what you can say here, it is neuroleptic malignant syndrome. Neuroleptic malignant syndrome can be, you cannot say it is neuroleptic malignant syndrome because it will be seen with psychiatric medications. Nowhere it has been mentioned that it has been used in the psychiatric medications, right? So all these features, they point me towards malignant hyperthermia. So no confusion is there among the students also. The answer is very clear, dantrolene sodium. There are some 4 or 5 questions which are clinical based scenarios in anesthesia. The first clinical based scenarios which has been repeatedly asked in your entrance examination, the clinical presentation of bronchospasm under anesthesia. Okay, that's your homework. If you have to do, you please go through it, the clinical presentation. The second one which is commonly asked is the laryngospasm clinical presentation. Laryngospasm clinical presentation. The third one is the anaphylactic shock clinical presentation. Anaphylactic shock clinical presentation. The fourth one that is repeatedly asked is the malignant hyperthermia clinical presentation. The fifth one is your thyroid storm. So from anesthesia or some surgical point of view, so these 5 clinical areas are repeatedly asked in your entrance examination. So this year or last year also they have asked about malignant hyperthermia. Clinical presentations are very, very important, right? So in all these things, bronchospasm, anaphylactic shock, there is a classical clinical presentation. What is this classical clinical presentation? In bronchospasm, it is shark fin pattern of EtCO2, shark fin pattern of EtCO2, whereas in laryngospasm, it is the presence of stridor. In anaphylactic shock, it is hypotension, tachycardia, wheezing, etc., etc. Right? Malignant hyperthermia, already we discussed it. Thyroid storm, already we discussed. So please, whenever you are reading the subject, please write down on one page the clinical presentation so that this pattern of questions, you will, without any confusion, you can answer these questions. Shall we move to the next question? Right. The next question is a 40-year-old female on administration of neuromuscular blocker, developed erythema, flushing of face, neck, trunk and hypotension. Just now I am telling you the third question is in front of you, right? What is the diagnosis, or which of the following drug is responsible for this? So first, if you can make out the diagnosis, the answer is in front of you. What is the diagnosis? Hypotension, tachycardia and erythema. The classical diagnosis is of anaphylactic shock. Anaphylactic shock. Okay, so once the diagnosis in front of you, what is the most common cause for anaphylaxis? So the most common cause for anaphylaxis is antibiotics. In your clinical practice, the most common cause for anaphylactic shock is antibiotics. The second most common cause in your clinical practice is muscle relaxants. Muscle relaxants are notorious to cause anaphylactic shocks. Any muscle relaxant, it can be depolarizing or it can be non-depolarizing muscle relaxants. In non-depolarizing muscle relaxants, more specifically, there are 2 categories, steroidal groups and benzyl isoquinoline group. And I have been saying in the video many times, even in the revision sessions also I have said, benzyl isoquinoline groups are notorious to cause anaphylactic reactions. Benzyl isoquinoline group includes atracurium, cis-atracurium, mivacurium. Okay, right. That's the second most common cause. The third cause is the third common cause for anaphylactic shock. As per textbook in the recent edition of Miller, that is the standard anesthesia textbook, it is written as chlorhexidine. Chlorhexidine. A slight change from country to country. The fourth most common cause is local anesthetics. That's the reason why when you are an intern, you might have written this order during your pre-operative visits. Pre-operative instructions, whenever you are working in surgery ward, gynec wards, etc., whenever a patient is posted for surgery, you might have written this instruction, xylocaine test dose, lignocaine test dose, right? Do you know why you have written it? Because local anesthetics are also notorious to cause anaphylactic shock. Again, local anesthetics, depending on the structures, there are 2 categories. The first one is called ester group. The second one is called amide group. Out of esters and amides, esters are notorious to cause anaphylactic reactions. So can you see here, from anesthesia, esters benzyl isoquinoline group are very, very notorious to cause. Now, let us see the options and come to a conclusion. Rocuronium, pancuronium. Rocuronium or pancuronium, we don't know what exactly they have asked. Both of them are not correct. Why? Because they are steroidal groups. Steroidal groups are very, very stable structures. Okay, so they are not common cause for anaphylactic shock. Next one, vecuronium. It's also steroidal muscle relaxant. So that's also not a common cause, right? Atracurium, yes, atracurium is the correct answer in this situation. Sir, why not cis atracurium? Again, I have been telling you many times, many people must be knowing this. Many students have also marked it right because we talk to many students. Cis atracurium, cis means what? Cis means isomer. The advantage of using isomers in clinical practice is whatever the parent molecule, cis isomer has the same features like parent molecule. So, cis atracurium is the isomer of atracurium. But what is the good point about isomer is whatever the negative points of the parent molecule are there that are not present in the isomer molecule. So, what are the negative points of atracurium? Atracurium is known to cause anaphylactic reactions. That's the first one. The second one is prolonged infusions of atracurium produce something called lordocine. Lordocine is which crosses your blood-brain barrier and it is known to cause seizure episode. Whereas these two negative features are not there in cis atracurium. Cis atracurium is very, very stable. It doesn't produce histamine. So, very tricky question, right? So, if you remember only one part of the question, you might have marked it wrong or you might get confused in the examination. But it is very commonly asked. Cis atracurium doesn't cause histamine release. That's the reason why we prefer cis atracurium more than atracurium. And coming to lordocine, lordocine production is very, very minimal when compared to atracurium. Okay. So, out of all the four options, what is the correct answer? The correct answer is atracurium. Right? Shall we see the next question? The next question that has been asked. Following a building collapse, a male patient was brought to the with copious amount of debris. In the mouth. There is a building collapse and lot of debris is there in the mouth. The following procedure is done. Which of the following statements is true regarding the procedure? Yes, this question has been shown or demonstrated in our video lectures also. What they are doing here? They are putting a needle in front of the neck. Somewhere here it is the neck. It might not be the exact image what they have showed, but many students have recollected that there is some needle they are inserting. So, can you imagine there is a building collapse? Very simple logic. Entire thing is there. So, conventional laryngoscopy is not done. Right? Whenever you encounter any trauma case, what is our protocol? Many surgeons might have also told you ABC. What do you mean by ABC? Airway, breathing, circulation. Right? Now, conventional way of holding the or controlling the airway is by doing laryngoscopy and intubation. He himself in the examination hall, he said that there is lot of debris in the mouth. If something is there in the mouth, how can I do the airway management? Right? So, I am not doing any laryngoscopy here, but the patient, as per the protocol, we are managing the airway. How are we going to manage? Now, you don't think or you should not think that they are putting an LMA. What we are doing here is we are trying to get hold of the airway by puncturing your trachea, and this procedure is classical called cricothyrotomy. Cricothyrotomy. This is called front of neck access. Otomy means what? Making a hole. In between your cricoid and thyroid cartilage, I am making a hole. What is the advantage? I will get an access to the airway. I can supply the oxygen to it. This is called front of neck access. Temporary. Textbook has written many times and we have also told many times in the video lectures or in the revision sessions. I have said you temporary front of neck access. Temporary front of neck access. So, once you come to a diagnosis, what they are doing, let us see the option. It is used for effective ventilation up to 6 hours. The word itself is contraindicating. Temporary. Okay, let us see. We will not come to a conclusion. Let us see the next one. It is used to measure the central venous pressure. This is completely absurd option, right? Right? You cannot say that central venous pressure means I am putting the cannula in the internal jugular vein. Internal jugular vein is on this side, on the lateral side of your trachea. So, if in the image if they are puncturing the trachea, how can I measure the central venous pressure? So, that's also ruled out, right? It should be followed by tracheostomy immediately. Yes, This might be a right answer. Work of breathing is more than bag mask ventilation. This can be, yes, but here the patient is completely collapsed. Work of breathing will come only when you are spontaneously breathing. Right. This might not be a right answer also, or maybe any other option, because this is a recollected question. Some students said less, or some students said something like that. Work of breathing means the work that is done by the patient. Here the patient is completely unconscious with lot of secretions are there. So here there is no point in work of breathing. First I am trying to achieve the control over the airway. Right. So many students got confused. It is effective up to 6 hours. Nowhere we can do it for 6 hours. So this is also a wrong answer. Okay. So out of all the given 4 options, the most appropriate or the most closest answer is it should be followed up by tracheostomy. Why? Because in needle cricothyrotomy, here they are showing a needle, right? They are putting a needle cricothyrotomy. There are 2 types are there, needle and scalpel. Needle is commonly done. Why? Because needles are very commonly available. We take 14 gauge or 16 gauge needle, we will puncture it in your trachea between cricoid and thyroid cartilage, and I will remove the needle. Cannula will be there. Through that cannula, I will ventilate. Okay, that's only temporary measure. So can you see here, I cannot do it for a longer period. 6 hours is pretty long period. 6 hours we cannot, because the real problem, I have done this needle cricothyrotomy many times. Like, in my 15 years of my practice, I have done it for around 6 to 7 times for my patients, electively or an emergency basis. The practical problem what I have faced is the cannula, what we are inserting, 14 gauge, 16 gauge cannula, I have inserted, I removed the needle, I continued the ventilation, but the problem is the cannula tip is there, no, the cannula, that will be bended. The moment it is bended, you cannot ventilate the patient. Have you understood it? So it should be immediately temporary front of neck access. So it should be immediately followed by tracheostomy. That should be your closest answer, depending on the options. Again, I am telling you, if this option was not there, if someone asked me, can it be ventilated? But practically 6 hours, we never do it. 6 hours, we never. Even for scalpel cricothyrotomy also, that cricothyrotomy itself is a temporary measure. It should be immediately followed by tracheostomy. Why tracheostomy? Means tracheostomy, you can definitely secure the airway. Right? You can definitely secure the airway. That's the last resort in my securing the airway. And most of the times, tracheostomy is done by the ENT surgeons. And in this kind of situation, you don't expect an ENT surgeon to be coming there, standing there and doing the tracheostomy. Right? So we might be doing a percutaneous tracheostomy in ICUs, but here this is a casualty situation. So most probably the image what they are showing is a needle cricothyrotomy, and the commonest thing that will happen is the kinking of the catheter. So very important is to go for tracheostomy as quickly as possible. So that's the closest answer that is available. Right. So these 4 questions are direct questions that have been asked in your entrance examination. These 4 questions are directly asked in your entrance examination. So what is the take home point from this? Because at the end of each recall session, you should be getting some take home point. Can you see here, whatever the questions that have been asked in the 2024 NEET-PG that have been more or less repeated. The only way is they have not put the exact wordings what they have asked in your examination. Right? What is the important thing is, please understand it very clearly, that in the going days, because you all must be knowing after you wrote your examination, when you are suggesting your juniors also, my simple suggestion, get your concepts right. Because 4 questions directly from anesthesia, 2 more questions are there. One is the question of 2-year-old baby choking, some peanut obstruction, and completely unresponsive patient. That question will be discussed by your ENT surgeon. And there is one more question of pharmacology question is there, where which is a drug used for pheochromocytoma intraoperatively and preoperatively. Any subject, anesthesia like subject, what is the problem is, we get 4 to 5 questions directly from anesthesia, 1 or 2 questions from the other subjects. Right? If you want to secure a good clinical seat, you should be aiming for total 100% right in anesthesia questions, especially this kind of questions. Not all these 4 questions, the real task, the person we can tell that he will get a clinical branch, or those who get good ranks, etc. These are the students, they might most of the students, they will get right in those applicative pattern of questions or the integrative pattern of questions. Some of these questions are very straightforward, so there is no confusion. But the real task is, once you listen to the videos, get your concepts right, you know, whatever might be the subject that they are asking, whether it is an integrated pattern, whether it is a clinical application pattern, you can easily answer this kind of questions. So with this, wishing you all the very best for your future. Thank you all. Good day.